Welcome everyone, my name is Zsolt Huszár, and I'm going to talk about the risk factors of the cognitive decline in elderly population. I'm a psychiatry resident in the Department of Psychiatry and Psychotherapy clinic in the Semmelweis University, and our vision is, in the future, the cognitive decline will be avoidable by the widely used prevention programs, and that's why our mission is to assist in the development of prevention programs. We have two specific goals now. First, we would like to evaluate the association between the pathological beta amyloid and phosphorylated tau accumulation in the central nervous system, and by them the rate of the cognitive decline by our systematic review and meta-analysis. And second, we would like to estimate the relevance and the biological effects of different risk factors of the major neurocognitive disorders by our observational study. Here you can see the title of our systematic review and meta-analysis, investigating the association between pathological amyloid and phosphorylated tau levels and the rate of cognitive decline. About the background, since 2018, the American National Institute on Aging Alzheimer Association has defined the definition of Alzheimer's disease by purely biological changes. The diagnostic criterion is the beta amyloid and phosphorylated tau accumulation in the central nervous system, and these two proteins led to the Alzheimer pathology changes, the neurofibrillary tangles and the senile plaques. And all two these lesions play a central role in the development of Alzheimer's disease. It's not clear to what extent the presence of amyloid, beta, and phosphorylated tau accelerates the cognitive decline. That's why our clinical question is what is the prognostic role of pathologic amyloid and phosphorylated tau levels on the progression rate of cognitive decline. You can see we investigate two different populations, the cognitively unimpaired subjects and patients with mild cognitive impairment. The exposure, of course, the beta amyloid and phosphorylated tau changes, and we compare the lack of it. And the outcome is the conversion and the progression rate of the cognitive decline. Here you can see our systematic search and the flowchart selection. In the end, we had 76 eligible full text. And these articles measured the outcomes were very, yes, they used very different outcomes. Somewhere they measured the change from cognitive unimpaired to MCI, otherwise from MCI to Alzheimer's disease, the conversion. The exposure was just beta amyloid or with or without phosphorylated tau. And here you can see the conversion rate from MCI to Alzheimer's disease in beta amyloid positive subjects in a non-adjusted hazard ratio. You can see the heterogeneity of the results is moderately low, and you can see that the amyloid positive, beta amyloid positive exposure has a serious, significant impact. But you can remember that wasn't our main question, but the conversion rate. To what extent does the amyloid beta accumulation accelerate the conversion? And the answer is the hazard is 4.6 compared to non-exposed subjects. Here's the summary. This is the only systematic review and meta-analysis in this field. And the meta-analysis summarized different amyloid measurement techniques, such as some were measured from PET CTs, others were by lumbar puncture directly from the cerebrospinal fluid. And this is also a strength because we pulled together and we can answer the overall outcome, but also a limitation because it could be difference between the different measurement techniques. And other limitation is the incidence of the other risk factors is not known. And the other, if you remember, one of the population is the cognitive unimpaired subjects. And in most of the studies, the cognitive unimpaired group had some subjective but not measurable cognitive complaints. the clinical implication of the study that by then we can provide more precise prognosis, and by knowing the conversion rate, we will be able to determine the critical intervention timeframes. And the implication for research is that in the future, the impact of different intervention, pharmacological, non-pharmacological intervention, can be better measured by knowing that the hazard of the conversion is 4.6 in the exposed population. Let me talk about our second project, the risk factors of cognitive decline in elderly population. It's an observational study based on our outpatient clinic. You maybe know, the major neurocognitive disorder currently has no effective pharmacological or non-pharmacological treatment. Our best chance is just to slow down the progression. That's why to eliminate the risk factors and developing lifestyle-changing intervention programs in the early stage is the current best way to prevent. Our aim is the identification of region-specific risk factors, clarifying the role of cardiovascular disease, diabetes, and the late-onset depression, and different biological factors. Here you can see our clinical question: to what extent can the development of major neurocognitive disorder be predicted by the risk factors? We investigate the same population and the exposure of the lifestyle risk factors, like the physical activity or social activity, the medical condition like diabetes mellitus or cardiovascular disease, and MR changes and laboratory values, and the outcome, of course, the conversion to dementia. The clinical implication and the research implication to the disease prevention, of course, to be able to eliminate the risk factors and estimate the risk of the cognitive decline. Here you can see our protocol drafting, and here you can see our outcomes. The primary outcome is the conversion to dementia, and the secondary outcomes, the rate of the cognitive decline, and identifying the relationship of different risk factors and different subtypes of dementia, and to evaluate the performance of risk estimation skills in our population and developing prevention programs. Here you can see the overview of our research, and thank you very much for your kind attention.
My question is for your first topic. I saw on the selection flowchart that you had 76 eligible articles, but on the forest plot were just a few of them. So it was a subgroup?
Yeah, it is a subgroup because they express the results in a statistically very different ways, and we couldn't pull together. And this is our first results, the non-adjusted hazard ratio.
My question would be, I think cognitive decline is a very broad definition. Is there any standard definition for that? Because you mentioned cognitive decline and mild cognitive decline. So what is the exact definition for that?
Thank you, but there are exact definitions. The mild cognitive impairment is when the subject's able to manage their everyday life with a slow help. And that's the clinical implication. And by the neurological test, for example, the mini-mental state, there are defined levels of the mild cognitive impairment range and the dementia range.
Did you take into consideration the age, for example, in the first project? Or what was the subgroup analysis based on?
So the effect of the age on the cognitive decline is a lower magnitude compared to dementia, because, I don't know, in an age 100, normally you will be able to manage your everyday life. Maybe your memory will not be the same, but the dementia is a much higher and measurable problem.
Yeah, and my last question would be, was there a follow-up time for the articles?
Yeah, those, but this is a hazard ratio, and this compared the non-exposed group.
How many other outcomes are you planning to report?
This is a current question.
So your data table is not complete yet, is it?
It's not complete.
There's 76 articles, it's quite a lot.
Yes.
Have you had a chance to see what kind of laboratory measurement techniques they were used in this analyzing this beta amyloid? Because it's totally depend on techniques. If you are using like immunoprecipitation technique or mass spectrometry, there's a lot of difference, and so it's also going to influence for accuracy of diagnosis. And so, have you had a chance to see these results?
Yeah, thank you very much. This is one of the main questions, because somewhere they measured by PET-CT, somewhere directly from the cerebrospinal fluid and by the mentioned technique. But previously, there are huge data banks, international registries, and they decided the cutoff values, and they measured to compare the PET-CT results and the cerebrospinal fluid amyloid results.
Okay, thank you very much.